Hi, everybody. Welcome to Educating and Empowering You. It is our April edition 2024 with the Boone County Hospital Foundation. We are excited that we are back in person at the hospital. We are also obviously streaming here live to you and then recording this as well, and it will be sent out on all of our various social media platforms and also on our website. So please take the opportunity to go out and find all of our past and upcoming programs as well. So today I'm so grateful to introduce Dr. Erickson. He will be presenting to us on foot health and some of the new and up and coming advancements happening with foot health. And we're looking forward to having him present to us here today. So I'll turn it over to him to get started. Thank you.
Excellent. Well, thank you, Sarah, and thank you to the foundation for allowing me to have the opportunity to do so. Thank you for coming. It's good to see people in person as well. This talk will admittedly be probably about a mile wide and an inch deep, which I feel like is appropriate for something where we're talking about a lot of different things. And there's always the caveat that this can, there'll be cases where what I say applies and cases where it just doesn't apply, because every patient's different, every foot's different, every ache and pain is different, and it can be very similar to one thing, but then in reality it could be something different. And so we will talk about cover as much ground as we can, and talk about the things that we most commonly see in the foot and ankle clinic, and hopefully answer some questions as far as what we do. So foot and ankle they are certainly workhorses within the body, and probably underappreciated until you have troubles with them. To put it in perspective, when I say they bear a lot of weight, I mean they bear a lot of weight and a lot of force. For every pound of body weight that you have, if you're running, you put 7 pounds of force through the foot and ankle, right? So a 100-pound person, 700 pounds of force. A 200-pound man goes for a jog, every step you get 1,400 pounds of force going through the foot and ankle. And so there's a lot of reasons why people develop stress fractures and develop, these types of overuse injuries that can slowly develop over time, or just feel like they come out of a blue, because we don't appreciate the fact that, running or jumping or doing things like that could demand so much of the structures within the foot and ankle. On top of that, they perform various movements. And so you will have a lot of people, hey, look at me managing the waiting room in the lobby while we're talking. I'm gonna pat myself on the back. While you're walking on uneven surfaces, you have multiple joints within the foot and ankle, 26 joints within the foot that accommodate for that type of motion and allow you to do the things that you need to do, and you do without thinking about them on a daily basis. And so they are complicated, and they are pretty remarkable, and yet underappreciated. So here are the most common things that people come in to our clinic for if they have aches and pains and are having troubles with their feet. And we'll talk about each one of these in depth, and then a little bit more depending on how much time we have. So plantar fasciitis is by far and away the most common cause of heel pain in adults. It generally comes on gradually for folks. It's worse after rest. It's pain right in the bottom of the foot, in the heel region. And it's due to inflammation of a structure called the plantar fascia. So the plantar fascia is this piece of tissue that kind of runs right through this region here. It works to help support the arch, and it does so by preventing collapse of the arch. So that goes under tension. You can appreciate that if the arch is here, these structures want to collapse. That causes this whole portion of the foot to want to elongate and stretch out, and the fascia prevents that from happening. If we're doing something, especially this time of year, where maybe we've been sitting inside trying to avoid the cold here in Iowa for a few months, and then we're like, okay, it's time to start working again and start walking and exercising, and we get out and we start moving more, demanding more of the structure. It's not used to having that tension, that level of tension on it, and so you can start to develop these micro tears And this small level of inflammation that can grow into a lot of inflammation right where it inserts into the heel bone. And gradually it gets worse and worse. Usually for folks, it's worse in the morning. Sometimes it kind of peaks in the morning. You got real bad 10 minutes as you're up and moving, and then things get better. And then it kind of gradually comes back towards the end of the day as structures begin to tire again. There are a lot of ways that we can make this better. But before we do, we'll look at some x-rays. Radiology for plantar fasciitis isn't something that, like x-rays isn't something we commonly do because it's usually a soft tissue issue more than a bone issue. And the exam can kind of tease out how much of it's bone or soft tissue. Anybody that has I should say anybody that's probably north of 40 years old or so, is going to have some level of a heel spur. And so if I lost my laser bone here, but that red arrow will show you that, if we take x-rays and we see that heel spur, that's a sign of what's going on within the foot, but it itself isn't causing you the pain. If it was, then the only way to get you better is to take you to the operating room and remove the spur, because we can't get rid of bone spurs like that unless you're physically removing them. Rather, that spur is only going to cause you pain if it's fractured, and that happens so infrequently that we don't have to worry about it. It is right where the plantar fascia inserts into the heel, and so that tension causes bone to elongate. Bone's is living tissue, and it will continue to remodel itself based on the forces that are going on there. That's why, when people are sitting in a bed, if they have to be healing a surgery, they lose a lot of the strength from their bones during that time. It's because bone metabolism requires us to be using it in order to make it stronger. Similarly, if you're constantly tugging on bone, that bone's going to elongate because it says, hey, this is where the force is. This is where I need to, make it stronger. Reinforce is the word I was looking for. Reinforce myself. And you start to develop these bone spurs. Getting them better. Come on now. As far as the feet, so feet will get bigger in pregnancy because of swelling. Structurally, they'll actually spread out. It's almost the opposite issue, where there is this is getting back into my med school days. There's a hormone called relaxin that causes the ligaments within the body to prepare for birth, right? So it relaxes all the ligaments within the body, and it doesn't just do that to the pelvis. It'd be kind of nice if it was just that, but it hits everything. And so for that reason, you can develop, my wife had this happen, where she has a really bad flat foot because of her first pregnancy. And sometimes that causes pain and things where during pregnancy, she wasn't wearing shoes, or maybe I don't know. I'm not judging that, right? Whatever the case is, she had that elasticity happen and stretched out the ligaments in that foot, and so she, can have that issue. It's a common happening. The way that we get plantar fasciitis better is relatively simple. We do very simple things consistently. And we can get rid of the inflammation within the plantar fascia. So having something to hold up the arch so that way we don't have that springboard mechanism happening over and over again with every step is very helpful. That's an orthotic. It needs to be a rigid orthotic or a semi-rigid orthotic. The knee-jerk reaction is my heel feels like it's bruised. I should go get a gel insert and put that in my shoe because it's going to feel better if I'm walking on it. And it does, but it doesn't do anything to get rid of the underlying kind of biomechanics that are causing the problem. And so putting something underneath the arch is going to help hold it up. So we take the tension off of the fascia is how this gets better. The other one is stretching. Your calf drives plantar fasciitis more than anything else. So a tight calf, if your foot isn't bending up the way it's supposed to bend up as you go through your normal gait cycle, then we are increasing the force through the entire bottom of the foot dramatically, just because it's not moving the way it's supposed to in the calf. And in America, anyways, the most common cause of plantar fasciitis is going to be that it's called an equinus contracture, or tightness in the calf muscle. And if we can stretch that out, then a lot of foot issues get a lot better, and plantar fasciitis is chief among them. So wearing the right shoe gears, NSAIDs, it's a highly inflammatory process. So if you can take ibuprofen or Aleve, that helps out a lot. Rest and ice. We can also talk about physical therapy. If, first line of conservative stuff doesn't work, we can also talk about injections and taping, all kinds of things. Less than 10% of people that have plantar fasciitis, and even people that come into my office for plantar fasciitis, less than 10% of those need surgery. This is something that generally gets better without. And so here's some diagrams on how you would freeze a 20-ounce bottle of water, roll that over the foot. Or I usually say just put it on the ground and run your foot over it that way. That looks way too cold on your hand. Using a ball, a golf ball, baseball, whatever, can kind of help break up some of that tissue as well. And then these are all mainly ways to stretch out the calf, like we talked about. Yes, some of it's into the foot as well, but the more that you stretch that calf muscle, the better you're going to do. If it comes to surgery, there are two main approaches that you can go about addressing this. And one is through an endoscopic approach, meaning we make a real small incision, and then we put a camera in there. Through that camera, you can advance a special kind of a knife that just cuts the fascia. And it's a small incision, about big enough to put a number 2 pencil through. And so it doesn't have to be big and open. You have the benefit of a smaller incision, but I'll tell you, I rarely do these when we have to take someone to the operating room. Rarely do I do them this way because you're limited to just doing a single procedure. And I have found that most people that have plantar fasciitis that doesn't get better, it's because it's teamed up with something called tarsal tunnel syndrome, which we'll talk about next. And through a mini open procedure, like you see on the picture on the left, you can address both of those through a single incision, and it's actually less traumatizing to the patient and to the tissue to do it that way. So tarsal tunnel syndrome frequently masquerades as plantar fasciitis. Anytime we have nerve pain, nerves can do all kinds of weird things and can present with pain in atypical fashion. It can be point tenderness, it can be pain in one location, it can be shooting or radicular pain, it can be a stabbing, it can be burning, it could be tingling, you could have numbness, it can be any of these in any combination. And so with tarsal tunnel syndrome, the thing that's reproducible on exam is where we initiate that pain. Regardless what the pain is, if I put pressure on the distal tarsal tunnel and it's kind of sparks that pain, then we know what's causing it, right? And it's not necessarily the plantar fascia. As we look at the picture here, you can see this little nerve coming right down this area, runs right underneath the plantar fascia. It's called Baxter's nerve, or the medial calcaneal branch of the tibial nerve being this guy here. As it goes through the as it goes through the tarsal tunnel, we put pressure on there, and it shoots nerve pain down to the bottom of the foot. And sometimes that pain is because of the plantar fascia, and sometimes it's because of the nerve, and most of the time it's a combination of both. And so we can release both doing the same procedure if need be. So here's kind of a cross section of this. We've heard of carpal tunnel syndrome. It's the same phenomenon where we have a very narrow passageway in the body. This one's just down in the foot instead of in the wrist. And if we have, in this structure here, this is called the flexor retinaculum. This is a deep band of tissue that holds those structures down to bone. And then we have a few tendons. You got 3 tendons, the nerve, an artery, and a vein. If any of those tendons are swollen or inflamed, then they swell, and swelling creates, takes up space. And if it's going to take up space and there isn't room for it, then it's going to aggravate everything else within the tarsal tunnel. Most notably, the nerve is usually the thing that barks first. Sometimes you can have just worse tendon pain with that as well. Commonly, varicose veins will cause this, where that will, you have any swelling in your leg and you're having some of these enlargements of the veins, it might not even be to the point where you see, those cords running up your leg like we've seen before. It could just be that they're ever so slightly swollen, but this is a narrow part of the body. It's a narrow tunnel. And so that extra swelling or instability within the wall of the vein can put pressure on the nerve and can cause some of the symptoms. Treatment, it mimics plantar fascial treatment very closely, right? We can do injections, we can do, rest and ice, like we talked about. Wearing proper supports, addressing different foot deformities can improve some of those symptoms quite a bit. Occasionally, we need to do steroid injections, and every once in a while, it doesn't get better. So then we talk about decompressing that nerve, which is a surgical procedure where we cut the retinaculum and just give it more space. Achilles tendonitis is another type of heel pain, right? And so this is heel pain not on the bottom of the heel, but on the back. And it's also very, very common, especially in people in my age group, those 40 males who maybe have a busy life during the week with kids at home, and then you're finally trying to go and do something active on the weekend. And again, the body kind of deconditions. It's not used to those types of forces that we were talking about earlier. And that can cause inflammation. It can come up in one of three areas. You can get it up here in the myotendinous junction, which is up in the calf muscle, right where the muscle turns into tendon. You get it down at the critical zone, which is more right in this region. We call it that because there's really bad blood flow there. It's the most common spot for ruptures to happen. So if we have Achilles tendonitis in that region, it kind of, we might treat that a little bit more aggressively than if it's a bit higher. And then you can have insertional, which is down here where it goes into the back of the heel bone. And that usually is more of a prolonged issue. It's less of a sports injury and more of just kind of a chronic buildup of symptoms. The contributing factors, we talked about a tight Achilles tendon or a tight calf, repetitive stresses. It can be a sudden injury. It can be a sports injury. You come down wrong after jumping. Or for some folks, if you're plantar flexing your ankle, right? You're walking around on high heels or on wedges for long enough that we start to tighten up the calf. And then you go to flats right after that. And so you're demanding, you go from, demanding the Achilles tendon to function in a high level in a plantar flex position. And then we, bend it straight up to 90 degrees and then ask it to do the same thing in a different, resting state. Then it can cause that same type of demand and stress to it. On x-rays, again, not always something we take x-rays of, although sometimes we do. This is a posterior heel spur. So you can see this patient gets the routine heel spur down here on the bottom that almost everybody has. This patient also has a heel spur right where the Achilles tendon inserts. The problem with this one is that this one does cause symptoms frequently because you don't have a nice healthy fat pad like on the back as you do on the bottom. And so you don't have the padding around this heel spur. So it's going to irritate with shoes. If anything touches it, these will be the folks that come in and are like, I would rather wear my open back, slippers than wear a pair of running shoes any day of the week because that heel counter aggravates it. To which, yeah, I get that. That makes sense. And so we can talk about how we manage these types of things too. The goal, if there is a trend here in my presentation, almost everything, you have to fail conservative therapy first, right? Like most of my practice, as much as I love doing surgery and I enjoy doing surgery, vast majority of it is trying to keep people out of the operating room. And most of the time we can do that successfully. And this is no different, right? Even though you have that big nasty heel spur on the back, a lot of those folks will do just fine if we teach you how to manage your activities and your shoes and what you're doing in order to keep the pressure off of it. We're not going to get rid of the heel spur, but we can make it so that way you don't have as much pain or as pressure with certain activities. So again, anti-inflammatories, if you're able to take them and you're not on any medications that contraindicate it, then it's a great tool to get rid of some of the inflammation. I do find that taking NSAIDs in a way that you take almost for like a more concerted effort for like 2 weeks, so like never miss a dose for 2 weeks straight. And a lot of times that can almost mimic the potency of an injection without having to break skin. We can get rid of a lot of that inflammation that way. Otherwise, if we just take it every once in a while, inflammation tends to build on itself. Inflammatory changes tend to upregulate themselves. And so you can decrease the inflammation to the point where it's not hurting as bad, but then it's just going to come right back up. And you end up taking more pills in the long run. This is anecdotal. I don't have a study to promote it, but in practice, we see it frequently where you take it for 2 weeks and then we go to as needed and the pain's gone versus I've been dealing with this for months, taking a pill every once in a while when the pain got bad enough to really get my attention and I just never broke that cycle. And so we can do NSAIDs. Ice is very helpful. Rest, not a lot of people will rest when I tell them to. Hey, that's okay. We want to keep people moving. And heel lifts. So this would be one area that seems a little bit to contradict itself, but a tight calf is going to cause the issue. And so I'm telling you to put a heel lift in, which is going to make your calf tighter. It's like, yes, but it's also taking the tension off of this. And so you have to do the stretching along with the heel lifts. Otherwise, it's going to, make itself worse. So as we look down at restoring function, physical therapy is golden, and it works really, really well for this. And we have an awesome team here at the hospital to help people get through a lot of these aches and pains. And they save a lot of folks from having to go to surgery. And so physical therapy is wonderful. Stretching exercises, doing those on your own at home is imperative. And sometimes night splints or even custom bracing can be helpful. If it does come to surgery, it's an involved surgery, especially if we have to resect that heel spur. You have to reflect the whole Achilles tendon off of it. So you end up having the Achilles tendon here and here. That Achilles tendon usually is diseased and thickened. And so we have to remove any bad tissue from the Achilles tendon, as well as removing that heel spur in the bottom of the picture there. And then we use anchors and suture in order to get the Achilles tendon back down, and you have to heal that before we allow you to get back to activity again. Patients typically heal very well from it, but it's a long road. Any surgery that we do takes a while to bounce back from, and so more reason to say let's exhaust all those conservative things as we can, and then see where we're at. We see a lot of folks with flat foot deformity. This can be boiled down to one of two causes. It can be congenital. It can be because of just your genetics and the way that you were born, or it can be acquired. It can be because of weakness within the ligamentous and tendinous structures of the foot that cause a collapsing of the arch over time. Usually, the latter shows up with more arthritic changes, and it shows up later in life than the congenital type of flat foot deformity. And so we do treat those things slightly different depending on the patient and what other symptoms they have. From a conservative standpoint, both do fairly well with orthotics and bracing. They can also do well with different types of functional supports and physical therapy. There are ways that you can strengthen the foot and ankle and the tendons that are going across that ankle joint in order to help your body accommodate for having a flatter foot. And if you do that well, a lot of times you don't have any pain, in which case, who cares, right? It doesn't matter if your foot's flat, if it's not hurting you, right? But it does mean that you should pay attention to it, and you should do the home exercises that help to strengthen things and help prevent injuries in the future and help prevent arthritis and things like that. Because again, surgery consists of a reconstruction, which is we could do an entire talk just on flat foot surgeries, as far as the different types of surgeries that we do and different, when do you do which procedure and all of those types of things. X-rays are a very important part of this because you can have different deformities within the foot that cause the flat foot deformity. This one mainly is because this talar head is dropped. That talar head drops mainly because the calcaneus slides out to the side, which then causes the whole flat foot or the forefoot to respond in kind. These two angles should be parallel, this one here and this guy down there. They should be pretty close to parallel, and you can tell in this case they clearly are not. And so that would be somebody that would take some work to get back up. As we look at different surgeries, you can see this procedure consisted of a first metatarsal cuneiform arthrodesis. So they fused this joint in order to help provide more stability to the medial column. But in doing so, they were also able to elongate the outside here. So you stretch out the heel bone. That helps bring things around. And then fusing joints and rebalancing tendons as well is usually a piece of the puzzle. For more the congenital side of things, a lot of times it's fusion procedures where we just say, you know what, there's so much arthritis in these joints. If we realign everything as best as we can, you're going to probably be in more pain than if we didn't do surgery. And so it's better to resect the joint entirely, hold it in the right position, put hardware across it, and then allow those two bones to fuse together. So you get rid of the joint, which seems, ridiculous and severe, except that that joint hasn't functioned normally, usually at that point for decades. And so this patient has already accommodated for the fact that they don't have a subtalar joint. Now we're just getting rid of the pain that's associated with the movement that's currently there. So those patients can do really quite well. Bunions are very, very common. Most people know somebody that has them, has suffered through them. Usually there's a great aunt or grandma or somewhere. Again, it can be congenital, right? It can be that it's just these are in your genes. This is how your body developed. It can also be because of degenerative changes or weakness within the foot that causes this to develop. Once they start to develop, it's very hard to stop the progression, and it's even harder to reverse it, if not impossible. However, it's not impossible to get rid of the pain associated with them. Again, just like a flat foot, we're probably not going to create an arch conservatively. We're not going to get rid of the bunion by doing conservative means. But a lot of times you can make it so it doesn't hurt anymore, in which case, who cares, right? Go live life and do the thing. Bunions cause pain because of three main things. One is this bump, right? You get this bump right through here that can rub on shoes and cause irritation. It also can rub on the second toe up in this region, and that can cause a lot of irritation and cause callousing and things like that. It can lead to hammer toes, which we'll talk about next, where that big toe is the boley that kind of gets underneath the second toe. The second toe then has nowhere to go but up, and so it starts to develop a contracture. And then it can also happen, or you can have pain with a bunion because of arthritis of that big toe joint, which is right in this region here. The important thing is that it's more than a bump, right? Like as we look at this structure, what's happening isn't that you're growing some extra bone growth on the side of your foot. The problem is that the first metatarsal, which is this bone here, is losing its stability back in this part of the foot. So this is the metatarsal cuneiform joint. This is like almost to the ankle as far as like where you're at in the foot itself. It's a long bone, and as you lose the stability in the midfoot, the head of this bone starts to project out the side of the foot up here. And so as it's growing, it's not that you're growing extra bone, though you do grow a little bit. It's mainly that the head of the bone is rotating out and pressing out to the side of the foot. That's why the big toe starts to go the opposite direction, as you have tendons that go across that joint also, and it's almost like a bowstring effect, where the tendon stays straight and it just kind of tugs the big toe off to the side because the middle of the bow, so to speak, is going medially. We talked about pain and soreness, redness and inflammation, burning numbness. There is a nerve that runs right over this area. There are two of them, but the dorsal nerve causes more pain than the plantar, and they call it Joplin's neuroma because we in the medical community are an arrogant bunch and we put our name on everything that we can. And so whoever Dr. Joplin was, he named this, kind of forever canonized as such. So that can cause pain. How we treat it is going to boil down to, again, conservative versus surgical treatment options. Depending on what's causing the pain, you can use toe spacers, you can wear orthotics, you can make sure that your shoes aren't putting too much pressure on that area. You can have shoes stretched if necessary. We can do steroid injections if it's more of an arthritis type of a pain. All of those things can be helpful. And if they fail, then we can talk about bunion surgery. So a bunionectomy typically is done in one of two ways. You can do a head osteotomy where you cut the bone in half up here, you shift it over, and then you put a screw across it to heal it. So we're essentially creating a new deformity to correct the old one. But for a lot of folks, it works really, really well. Most of the time when we're taking somebody to surgery for this, it's because of the midfoot issue though, right? And so when that happens, we need to fuse the joint back in this region. So that way we can actually correct the whole deformity and not just be focused up on the head of the, around the bump, so to speak. This is what's called an Austin osteotomy or a distal chevron osteotomy, where you just cut that, you shift the head over. Because it's shaped like a triangle, it's actually a very stable osteotomy and only usually requires one screw. In fact, when it was first described, they didn't fixate it at all. They just impacted it and said it's good. Now we use screws to help hold things in place. Hammer toes are caused by like an imbalance. I told you we're going to be an inch deep and a mile wide, right? We're covering a lot of things and not spending very much time on any of them. Hammer toes are caused by a tendon imbalance within the foot. There are numerous tendons that go across what's called the metatarsophalangeal joint, the ball of the foot, and go into the toes. If any one of those tendons starts to contract down and grab harder than the rest of them, then it falls out of balance. Then we develop different contractures of the toes because of that. By the time somebody's coming in to talk about surgery for this, usually we're going to have to, again, fuse joints. We're going to have to get rid of the bend in the toe and lock it in place so it never comes back again. But there are ways that we can get rid of the pain that's associated with the deformity without necessarily getting rid of the deformity by itself. Usually, you're dealing with nail and callus issues at that point. You're going to get a really bad corn on top of a joint, and those corns, as much as a callus shouldn't hurt, if it's in the wrong spot and it's over a bony prominence and it's rubbing on a shoe, it can hurt like crazy. So sometimes it's just as simple as, well, let's just trim down that corn. If that's all it takes, and you have to have that done every several months or whatever the case is, it's way easier to do that than it is to recover from a hammer toe surgery. But other times that doesn't do it well enough, and we have to go and talk about the surgery. The surgery, just like we've talked about before, can vary a lot depending on the patient, depending on the deformities. Sometimes you're lucky enough that all it's really doing is, I pushed that button twice, is working in the toe. Sometimes you have to go back into the foot some too. It just depends on the deformity and what else is going on there. There are pads and straps that will help to hold the toe down and straight. This is called a boot and splint. It's, for most folks, it's a really good way to correct that deformity and get rid of a lot of different causes of pain. But there are other ones too that, depending on the patient and depending on what's causing their pain, we might recommend also. Sometimes these surgeries require a bunionectomy as well, right? We talked about how if you have a bunion deformity, that big toe leans over towards the lesser toes, and it can bully around the lesser toes to the point where there's just no space. And so the only way that you can correct that hammer toe is to get the big toe out of the way. It'd be one of the few times that I'll talk to somebody about doing surgery on something that doesn't hurt necessarily in order to fix something that does hurt, because there's just no place to put that second toe without getting the big toe out of the way. That being said, some people, depending on the age of the patient and their medical comorbidities and like how safe they are to undergo a surgery and their likelihood of complications after surgery, all of that mixed together, sometimes the right answer is you amputate the toe. Even though it's not infected, it's like, well, you can heal a toe amputation in a couple of weeks. Healing a bunion procedure, that could take a few months. And for some folks, that's a lot of demand on them, not just socially, but as far as their medical conditions go as well. The foot and ankle, like we talked about, has a lot of different bones and joints. 33 joints and 26 different bones make up the foot, each foot, right? And so double that if you still have two. And because of that, there are plenty of opportunities to develop arthritis. Most commonly, this shows up in the midfoot. It can also happen right behind the big toe, and then in the ankle joint. And it can happen because of wear and tear or degenerative arthritis. Ankle arthritis in particular is much more common in a post-traumatic setting. So somebody that broke their ankle, and it might have been decades ago, or it might have been a year ago, it changes the way that that joint functions, and so that you can have more wear and tear. Also, sometimes there's enough damage done to the cartilage of the ankle joint itself when the ankle was broken that they can kill off those cartilage cells, and then eventually we don't have any cartilage left there. So you develop the ankle arthritis that way. There are ways to make it better. We are all very, very familiar with arthritis pains. It's pain and stiffness, swelling, and sometimes it can be to the point where it makes it hard to walk. Anti-inflammatories are helpful, just like anywhere else. Get rid of some of that inflammation. Bracing can be very helpful. Again, a lot of this is very dependent upon which joint specifically is hurting and how it's arthritic. For ankle arthritis, we can get a really good rigid ankle brace. If we can lock up that motion, it typically doesn't hurt. However, sometimes that can cause its own, a set of issues by locking up motion that we're used to having. Steroid injections can be helpful there as well. If it comes down to surgery, then this is one of those cases where removing the joint sometimes is better than having a painful joint. It's important to note that in the ankle complex, You have your ankle joint itself, which allows your ankle to go up and down, but then you also have a subtalar joint, which allows your ankle to go inside and outside. And so together they do circles. If we ever have to talk about doing an ankle fusion, you don't lose the inside and outside motion, which is actually way more important for folks than the up and down motion. If you have to lose both of those, then that takes some getting used to for people. However, losing the ankle joint motion, it's similar to when we talked about fusing other joints in the body. By the time we're talking about it, it's caused enough pain, you've lost enough motion that you're already accommodating for the fact that it's not moving much anyway. So now we're just getting rid of that last couple degrees of motion that you have in order to get rid of the pain that's been associated with that. Couple ways that you can do a surgical fusion. You can do it with screws, you can do it with plates, and we can even do ankle replacements in the right patient. It's a pretty narrow patient window as far as patients that would do well with an ankle replacement versus a fusion. And you have a higher rate of having to do more surgeries with an ankle replacement than a fusion. A fusion tends to be more of a one and done procedure, where if you have a patient in their 50s that needs an ankle replacement, that replacement probably isn't going to last them through the rest of their life. They'll have to have something done with it. And then depending on patient weight and what their demands are, sometimes the fusion's the better option. If you go back to the 80s and 90s, there were a lot of ankle replacements that were put in that were really not very good. So the long-term data on ankle replacements isn't very great. However, I bet it was before 2010, things really started to turn around as far as ankle design or replacement design and how these implants are being put in. And the data is already significantly better now, but it is still, in the realm of medical literature, we don't have 30-year data on the new replacements because they haven't been out for that long. And the things that we do have 30-year data on, they're not looking great because they're old generation models that are no longer being used and we've learned from and improved upon. So that's one of the reasons why I don't do a ton of these. And most of anybody that would need one, I'd be like, you're better served going to somebody that's putting these in more regularly. And so we'll make sure that if somebody qualifies for an ankle replacement, that we get them to where they need to be. Maybe someday we'll have enough literature to be able to put them in more regularly. As we look at x-rays, this would be a normal ankle joint, and this is a much more arthritic ankle joint. We're already up to 40 minutes. I'm probably putting you all to sleep. This is this is your ankle joint fusion, right? And here's that subtalar joint. This is the one that lets you go inside and outside. And so that's why that one is included there as well. Big toe arthritis also can be treated with steroids. It can be treated with orthotics. It can be treated with bracing, shoe modifications, and if need be, it can be treated with surgery. And it all depends on how severe the arthritis of the big toe joint is and what type of symptoms you're having. This joint in particular, you can develop a lot of bone spurs because of the arthritis, and sometimes it's just the bone spur that hurts, in which case you can do a joint sparing procedure called a chylectomy that allows for getting rid of those bone spurs and allowing more normal motion. And those patients can do really well. I usually caution folks that it's like a Band-Aid procedure. We're not fixing the underlying things that led you to this place. And so the chances are good you'll require another surgery further down the road, but maybe it's 10 or 15 years and you don't have to have a joint replacement or fusion done just because we got rid of the thing that's causing you pain now. And so that's an option. There are specially designed orthotics for this. This one's called a Morton's extension orthotic. It's a carbon fiber plate that extends underneath the big toe joint, and it takes a lot of the force from the big toe joint, so that way you don't have as much of that motion going through there. It has the benefit of being extremely thin, so you can put it into a lot of different types of shoes, and it can easily move from one shoe to the next and works very well. Injections are very, very helpful for this as well. And then we kind of boil down surgeries, if it comes to that, into 3 camps. You have the joint sparing procedure, which is what we talked about. You can do a fusion, which we've talked about in other joints, but you'd certainly do them here as well. And then you can do an implant. And this would be one that I normally talk people out of because, again, it's a high demand part of the body as far as an implant goes. And I'll show you an x-ray of one here in a second. Fusions, usually we put a plate on those, even though it's a small joint. By putting a plate, it's a strong enough construct for fixation that people can walk right after surgery, and you don't have to be non-weight bearing, which is a big deal for a lot of folks. Usually we can let you walk after surgery because you don't really want to. I mean, that is a piece of the puzzle, right? Like you're in enough, it's not really comfortable to walk, but you can do so safely. And so that is okay. You can see from this is actually just a hemi replacement. So this joint replacement, they just replaced half of the joint. But even with that, you lose a lot of bone when you do a joint replacement. And in this part of the body, when you don't have a lot of bone to work with to begin with, and then you lose a lot because of an implant that was put in, and then you have to take that out potentially at some point down the road, our revision options are limited. So if this goes south for any number of reasons, and maybe it's just the normal wear and tear of the implant and of the joint with time, finding a way to revise this and get it to something that will be another one and done surgery can be hard. You have to fill in bone voids. Sometimes you have to take bone from other parts of the body and put it into that part so that way we can actually get things to heal well. It requires a fair amount. And for that reason, it'd be a very narrow window of patients that I would even bring up a joint replacement for in the big toe joint. It's not a no, but it is a, well, let's talk about the risks of this and make sure that it's a good fit, because there are patients that benefit very well from them. And there are some surgeons that will say you should never fuse this joint. And I would disagree with them for a lot of reasons. But you'll find competing information out there. And that's the same in most things in life. So shoe selection, right? That's one of the most common questions, regardless of what people come in for, is what shoes should I wear? And there isn't a good answer for that, right? The right answer is we need to have the right shoe on the right foot for the right activities. And every patient, that's going to look different. I don't care what brand of shoes you buy, because whether you buy, the most expensive, Nike or Brooks shoes out there, they could tear your feet apart if they're not designed specifically for what you have going on in your foot and ankle. So it's much more important to me that you buy your shoes from somebody that knows what they're talking about and knows what they're selling you, and someone's going to take the time to make sure that they fit appropriately and that they have, the right design shoe for your type of foot. The shoe companies change things over, I feel like, at least quarterly. It's probably not that often, but it sure feels like that, to where it's hard to know what each shoe is supposed to be accommodating for. And so any list I've made in the past usually is garbage within about 6 months, because the shoes don't even exist anymore. And so going someplace where that's what they do is really, really important. There are some general guidelines, right? Like if you have bunion pain, then as you look at the toe box, you want it to be flexible. You don't want a toe box and a bunion that has these leather straps going across primary points of pain, and it's gonna hurt. It's gonna irritate things. You want to make sure that it fits appropriately. If you have a wider forefoot, then you need a wider shoe. If you have that Achilles tendon issue that we were talking about earlier, we have this big bone spur back there. If your heel counter is really rigid, you're not going to tolerate that one bit. However, if you have a flat foot deformity, a good heel counter is going to be imperative to making sure that that foot is comfortable and supported well in that shoe. And so we have to take all of these things into account and then find the right shoe, and then wear it for the right activity. I always feel like I'm a little bit of talking out of each side of my mouth, because my feet don't hurt. So I'm going to go for a walk with my kids and I'll wear flip-flops, right? Because they don't hurt. Now, I'm not going to go running in flip-flops because I'll probably pay for that tomorrow. Other people will have enough midfoot arthritis that even wearing flip-flops in the house is too much, right? And so you have to know what's going on in your foot, know what shoes are acceptable for each activity, and then pay attention to it and don't ignore it. Now, I had thought about diving into diabetes, and I'm just going to do this. You can't talk about foot and ankles, issues without talking about diabetes. Diabetes affects the feet in a lot of ways, primarily through two systems. It affects it through the nervous system, through what's called peripheral neuropathy. It causes your nerves to not work the way that they're supposed to work. The danger with peripheral neuropathy is that it isn't an all or nothing response, right? It's not a light switch where all of a sudden we have all kinds of sensation and now we have no sensation. If that were the case, people would be alarmed and they would take it very seriously. The problem is that it takes more and more stimulation to the foot to cause the same signal to the brain, right? So your brain's interpreting this signal as unchanged. The same signal is making it to the brain, but now it's taking a fire poker, right, to get into the foot in order to get that signal up to the brain. And your brain's like, well, shoot, I've had that pain for decades. It's never been an issue before. Now it's an issue. And so it's that reason that peripheral neuropathy is very sneaky and is very dangerous, because you have this false sense of security of decades and decades of, years and experience, knowing what pain you should listen to and what pain you shouldn't. And that's changing. So you can no longer trust your history. You can no longer trust your feelings. You have to trust your eyes and your hands. You have to look at your feet and say, okay, is there an issue here? Is something red? Am I bleeding? I usually say you wear white socks, not because there's anything wrong with pigmented socks, but it's really hard to ignore blood on a white sock, right? It's easy to miss that on a black sock. So things like that are easy tricks to make sure that things are, that you're catching them early. The most important thing is you have to catch issues early. If we do, people do well and you'll do fine. We can control blood sugars really well. If your A1C is above 8%, the chances of you having complications with foot and ankle issues goes up exponentially. If you smoke as a diabetic or a diabetic with an A1C above 8, then that is even worse. It's not like 1 + 1 = 2 as far as risk goes. It's like 1 × 100, right? Like we're really, really asking for trouble in that setting. The other way that diabetes affects you is through your blood flow. That is important because if we can't feel our feet, we're likely to develop wounds. If we develop wounds, and then we have this blood, peripheral arterial disease, so we have this blood flow disorder, then we can't heal them very well, right? We can't heal wounds well. We can't fight infection well. If we have to go on an antibiotic, the antibiotic gets to your toes through your bloodstream, right? And so you're also not going to be able to get the antibiotic there that you need to, and it compounds upon itself quite a bit. Prevention, 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 right? Like that's the most important thing when it comes to diabetes. And making sure that we catch things as early as possible. My staff downstairs knows that if somebody calls in and says, I'm a diabetic, I'm worried I have an infection, we're going to double book whoever we need to, even if it's nothing. I would rather send you home 100 times and say, don't worry about it, it's no big deal. And then be like, shoot, if you'd been here last week, then we wouldn't be talking about the operating room today. It's a big deal. We want to get you in and get things taken care of. Controlling blood sugars is really important. Doing your exercises is important. Neuropathy affects the feet through sensation, but it also affects the way that your body manages moisture to the skin. So diabetics are more likely to have bad calluses that crack, and calluses cause pressure. Pressure causes wounds. Cracks cause wounds, right? These things build on each other and can really make things a lot worse and a lot harder. Periodic foot exams are important, right? Even if you feel like you're stable. And if you're really stable, then just have your primary care doc do it at their normal, annual physical. Just make sure that they look and see everything's fine. And if they need a second opinion, then we're always available. But it doesn't have to be overly complicated. It just needs to take, some precedent, and it needs to take some, you need to take care and pay attention to it. Things to do is like, don't ignore pain, don't ignore changes. Don't try to fix things on your own, right? Get in, let somebody take a look at them. Medicated pads maybe used to be fine. They usually have an acid in them called acetic acid. Acetic acid dissolves tissue, and so it's one way that people will treat corns, and that's great if you can feel your feet. If you can't feel your feet, then you don't know if it's taking good tissue or bad tissue, and the acetic acid doesn't care if it's taking good tissue or bad tissue. So you can create wounds that way too. Wearing shoes is important. Wearing properly fitting shoes is important to preventing wounds and preventing injuries. And all of that together, prevention is important, right? So if you see something, if something's wrong, call and get evaluated. And again, we can talk about wound care. We have an awesome wound center here at the hospital. They do phenomenal work. And we use everything from the most basic dressings to the most expensive dressings and everything in between, depending on what that patient needs. And we could talk for hours and hours upon the sciences behind each of those. Not going to. Same with trauma. Like I didn't even talk about broken bones and broken ankles today. And that's something that we love to take care of. Hate to have somebody go through with it because it's not fun having a broken bone. But it's a rewarding part of our practice downstairs as well. So if you have an issue, if something is broken, if you're worried that something's broken or injured, you know, our ER, our walk-in clinics do a phenomenal job of doing that. The primary care docs do a great job. Sometimes time is of the essence, and getting into our clinic faster can actually impact patient care quite a bit. And so calling our office also is a good way to get in quickly and just say, hey, I think I broke my ankle, or I injured this. Can I get seen today? We'll get people in. We always will. It doesn't matter how busy we are. If somebody needs to be seen, you need to be seen, and we're going to make it happen. So calling the office and making sure that we get you in is kind of the way to go. That was a lot of words. A mile wide and an inch deep. So that's my crew. And any questions that we need to, yeah, right? You don't have to either, right? Yeah, sure. So most people ask that question with a hint of skepticism. We're like, how can you deal with feet all day long? And the joke is, if you stay below the knee, they're a lot of part of the human body. You don't have to go anywhere near because you're below the knee. And so that is, that's all fun and games. In reality, I thought I wanted to do ortho. And then I followed around a couple of ortho docs when I was in college. And I didn't want that lifestyle. And there were a lot of things that kind of built into that. In retrospect, like in my naivety, I think you can have a healthy lifestyle and be an orthopedic surgeon without a doubt. I know a lot of great orthopedic surgeons that are wonderful human beings. That wasn't my experience in the two people that I shadowed. And so I started looking at other options. I followed around a podiatrist down in West Des Moines, and he was a phenomenal doc. He took really great care of folks. Had a good work-life balance. I'm like, oh, maybe this is something. And then we're like, oh, wait, you actually get to do a lot of surgeries too. You get to, you know, fix things that need to be taken care of urgently and acutely, like fractures. But also you have folks that you get to build a relationship with too. And so you have more, you know, patients that stick with you for a while. And so you get that balance. So between that and the fact that, you know, it seems like you're hyper-focused when you're talking about just doing foot and ankle. But we do everything from, you know, skin tumors, like we'll do biopsies and surgical biopsies and things like that for different types of skin conditions, and all the way down to joint replacements, and, you know, and everything in between. Like you'll have some folks that, you know, all I'm doing is trimming a callus today, or, you know, cutting out an ingrown toenail, and that might seem like, you know, it's some people think it's beneath them and like, I shouldn't be trimming toenails. That'll be the happiest patient I see all day long, because their pain went from painful every step every day to all of a sudden they're leaving and they are pain-free for the first time in weeks. Versus, you know, somebody that had to have surgery, it's going to take a while before they're happy that they cross paths with me. And so there's that side of things too, where it's a very wide scope within a very narrow part of the body. Yeah.
I noticed that sitting, you raise your legs.
Yeah.
Like, as we're sitting in our chairs. Elevated.
Yeah, it can help, especially if you have, like if your veins aren't clearing fluid out of your legs as well as they should, and that happens to most people at some point in their life, then yeah, that can certainly be helpful. Mine's probably more from just being antsy. It's not very intentional, right? And exercise. Like I'm a little bit sore from, you know, riding a bike this morning, but so there's that too. But you know, absolutely, I think that the more that you change your position, you know, the better. If you have a lot of swelling issues, and that's another thing. I also, like, I'm wearing compression socks, and I do almost every day that I'm at work, just because my legs feel better if I do. And there are a lot of folks who are like, huh, really? Like, no, for real. And it helps. And they don't have to be medical grade compression socks, because those can be a bear to get on and off. All right. And so just any level of compression, get rid of some of that swelling down there can help out quite a bit. Yeah, absolutely. Absolutely. Yeah, especially with the diabetes thing. We flew through that for the sake of time. But if you aren't wearing socks inside your shoes, you have an extra layer of friction on the skin itself that's going to cause shearing types of wounds, can cause lots of issues that way too. Socks are important.
Oh my God.